all, I'm Dr. Diana Chapkin here at SCRC Fertility. So happy that you're here joining me today. We are going to speak about endometriosis and infertility. Now, of course, a lot of people's questions come down to, does endometriosis, if I have it, will that affect my fertility? Will that affect my chances of getting pregnant? And I will tell you that not necessarily. So there are plenty of women with endometriosis who have no issues conceiving. And there are also plenty of patients I take care of who have infertility who do not have endometriosis. But endometriosis, for a number of reasons, can affect a woman's chances of getting pregnant. So endometriosis is essentially a disease where the lining of the endometrium, the lining of the uterus, called the endometrium, there's certain cells in the uterus. And they're essentially supposed to primarily just stay in the uterus, in the lining of the uterus. If those cells implant outside of the uterine cavity, let's say on the fallopian tube or on the ovary or in the abdominal cavity or in the perineal cavity, well then that's an issue that essentially results in endometriosis. And when those cells become inflamed or get activated, women can have significant discomfort. They can have pain. They can have pain with their periods. They can have pain with intercourse, pain with bowel movements, or just pelvic pain in general. Now, some of those implants can lead to scar tissue in the abdominal cavity. And so if that scar tissue affects, let's say, our fallopian tubes or affects the position of the ovary, well, then that's going to just make it difficult from a structural standpoint for the egg to get picked up by the fallopian tube in an efficient way. And if the egg is not picked up by the fallopian tube in a productive way, well, then the egg and the sperm are not going to meet, and therefore infertility can result. So endometriosis, because of the issues related to scar tissue and structural changes, infertility may result. But endometriosis can also, we know, affect in some women egg quantity and egg quality. We know that women with endometriosis have a higher risk of having eggs that may be compromised, potentially also a faster rate of egg loss. And we know that fertility is very much related to ovarian reserve. It's related to egg number and egg health, quality of eggs. And so, there's essentially this concern that women with endometriosis may have a faster progression towards infertility than the average woman. And so the question is, okay, so if I have endometriosis and I'm trying to get pregnant, what should I do? What is essentially the treatment? And what I will tell you is that, this is a very individualized conversation, and I would say it's not even, just knowing that a woman has endometriosis and infertility is not enough for me to say, okay, this is what the treatment is that she should have. But I will tell you that thinking about fertility treatment sooner rather than later is really important to think about, because endometriosis is a progressive disease and can affect our structures in our like I had mentioned, in the ovary and the fallopian tube. It can affect the ability for the egg to get picked up appropriately because of the damage it may cause to the fallopian tube, and also because of the progressive effect of endometriosis on egg quantity and egg quality. So it is important to think about fertility treatment sooner rather than later, to essentially think about something like in vitro fertilization potentially, because again, if we're in a situation where a woman has infertility and she has endometriosis, progressing towards infertility sooner rather than later may be a factor. Now the question is there something specific that you can do to treat endometriosis that then may potentially fix your fertility? And, the answer is yes and no. So essentially, if, let's say, a woman's main issue, let's say, there's great eggs, great egg quality, great sperm, but let's say she has, some scar tissue around her fallopian tube due to the endometriosis, due to the inflammation there, potentially you can argue, well, that particular woman really only needs a laparoscopy. That's a minimally invasive surgical procedure where we could potentially just remove that scar tissue, release the fallopian tube, and then the issue is fixed. And then hopefully that fallopian tube is functional. It can pick up an egg, and fertilization can potentially take place. So that's potentially one option of how we can say, okay, maybe surgery could fix endometriosis-related infertility. But I will tell you, by and large, for the most part, and there actually have been pretty good studies that have been done on this. When women have significant endometriosis linked to their infertility, or they have significant endometriosis and they also have infertility, the treatment is not really surgery. We've actually done studies on this to show that you need to do a lot of surgeries on many women to show the benefit in one woman for doing surgery to improve fertility. But in fact, there are other treatments that can treat fertility related to endometriosis, fertility issues related to endometriosis, and that includes things like in vitro fertilization. So the same treatment that we would use for a woman who had obstructed tubes or low ovarian reserve, we would offer in vitro fertilization. That's by far going to be our best treatment for infertility in general, and also can be our best treatment for infertility related to endometriosis. Now, I'm not saying that a woman should not have her endometriosis really looked at, and I don't think that, and I'm not saying that women shouldn't have laparoscopies to diagnose and treat their endometriosis, but for the most part, that treatment is given if a woman has significant pain, discomfort related to her endometriosis. So if a woman tells me her only symptom related to her endometriosis is her infertility, well, then we do fertility treatments. Best one would be IVF. If somebody has pain related to their endometriosis and wants that taken care of, well, then of course IVF is not the solution. What's the solution? Other treatments. So potentially things like medications like birth control pills, Lupron, to kind of lower the estrogen, and that can sometimes stabilize endometriosis flare-ups and growth. Also laparoscopies. So as I mentioned, that's a minimally invasive surgical procedure where we can go in with a camera, look at the endometriotic implants, and we can, with laser focus, burn those implants or resect them. And oftentimes that helps with women's pelvic pain. But again, that sort of treatment, that sort of, laser fulguration, removal of endometriosis laparoscopically is not a fertility treatment. It sometimes can improve fertility, but by and large, that is used to treat pelvic pain associated with endometriosis. Fertility issues related to endometriosis, really the best treatment is going to be in vitro fertilization. And a lot of people say, well, how do I diagnose infertility? Well, infertility is diagnosed by trying to conceive for 6 months if you're over the age of 35 and not conceiving, or if you're less than 35, trying to conceive for about a year and not being able to conceive. How do you diagnose endometriosis? Well, I'll tell you, a lot of us clinicians have to have a little bit of a concern based on your history to think, well, maybe they have endometriosis. So if a woman is telling me that she has very painful periods, she has to stay home from work, she has pain with intercourse, pain with bowel movements, already I'm thinking, okay, maybe she has endometriosis. A lot of women will get laparoscopies to diagnose endometriosis. Now that is kind of like the tried and true way to really diagnose endometriosis. But you don't need a lot of evidence laparoscopically. You don't need to see a lot of endometriotic implants on laparoscopy for a woman to be diagnosed with endometriosis, or for that endometriosis to give her a significant amount of pain, meaning that women can still have small amounts of lesions seen on laparoscopy and still have significant pain. So that has to be taken very seriously, and that's a reason, again, why we want to fulgurate or resect that endometriosis. Also, the degree of endometriosis is not necessarily related to her fertility. So some women with small amounts seen on laparoscopy have infertility, and there are plenty of women who actually have pretty significant disease seen on laparoscopy who don't have infertility. But again, I think important to kind of take the whole picture into account, and to think about endometriosis is a very serious condition. And as a fertility doctor, of course, my goal is to help people towards their whatever goal they want with their family building or fertility preservation. And so, thinking about their endometriosis is really part of that, but I also have to think of the woman as, her whole life, right? She's not just coming to me in a vacuum trying to get pregnant or trying to preserve her fertility. She may also have pelvic pain that really needs to be addressed very seriously. And sometimes I'm the first doctor that a woman speaks to about their pelvic pain, because they kind of, push their pelvic pain sometimes under the rug, and then they just come to see me because they're trying to get pregnant. And sometimes fertility is just the first symptom or the first thing that they think to bring up to a physician. But a lot of times endometriosis is the underlying cause that really needs to be addressed, and really needs to be addressed throughout a woman's life. Because again, it is a progressive disease, so it needs to be taken very seriously. Somebody asked here, are there any blood tests that you should take prior to seeing a fertility specialist, or can we get that done with you? So I really like to make it, as least barriers as possible before coming to see me. So I actually don't think you need to get any blood work or honestly any workup prior to coming to see me. I think any sort of feeling where you think, okay, I'm having trouble getting pregnant, or I'd like to do some sort of fertility preservation, either egg freezing or embryo freezing, you're honestly more than welcome to come in for a consultation, whether you've had blood work or workup or whether you haven't. Anything you've had done, recently, I could potentially use and don't necessarily need to make you repeat. But anything that you will need to have done, I absolutely can order and make sure that we get it done. One of the most important tests that I get to assess ovarian reserve is anti-Müllerian hormone level. That's an AMH level. And of course, I'll need to get infectious disease testing and hormonal tests, but AMH is a really important one. But I absolutely can order it. You don't have to get it done before seeing me. Any other questions? So somebody has a good question about the Receptiva. So that's an interesting one. So that is a newer test that a lot of us do, where basically there is essentially this idea of silent endometriosis. So kind of going back to what we talked about endometriosis. So I talked about how endometriosis can affect structurally the fallopian tube, the eggs, and so the ability of the fallopian tube to pick up the egg, and therefore the ability of the egg and the sperm to meet. So that's crucial in terms of the endometriosis fertility story. Also, I talked about how endometriosis can affect egg quantity, egg quality, and as I said, it's a progressive disease, and that can affect one's ability to conceive or actually response with IVF or fertility treatment. So that's super important. Endometriosis, it's thought that potentially if there is endometriosis, that can potentially also affect the ability of an embryo to implant. So if, let's say, we have an embryo and we're going to put it in a woman's uterus, if the embryo is chromosomally normal, that's usually, we say it's about a 70% chance of pregnancy. But if a woman has endometriosis, the concern is that maybe there's this inflammation actually inside the uterus as well that prevents implantation or lowers the risk of implantation and a successful pregnancy. So if a woman has endometriosis, a lot of us fertility doctors, myself including, would say, well, if you have endometriosis, and we know that it's documented and we're going to do an embryo transfer, let's think about doing some sort of hormonal suppression prior to starting you on estrogen in order to do your embryo transfer. So when we do an embryo transfer, we'll have you take estrogens to thicken up your lining, and when we see the appropriate lining, we'll have you take progesterone. A few days after progesterone, we put the embryo in the uterus. But prior to starting the estrogen in women with documented endometriosis, we'll often think about giving you something like Lupron, either 1 or 2 months, to potentially suppress the endometriosis, to maybe lower that inflammation so that maybe we get better implantation. Now, there are very honestly few studies that back this up, but that's why it becomes a conversation. A lot of women don't really like the Lupron for 1 to 2 months because of the side effects that they experience. It does essentially put you in a medical menopause. Women sometimes don't really want to deal with that. And again, without the backup of significant data and not really great trials on this, it's hard to put my foot down about it, but it's something that we talk about as an option. So then the question, so that's I would say kind of like the story about the endometriosis and the effect of potentially implantation and what we potentially would do about it. Now, there are situations where there's this concern where people say, well, maybe I have endometriosis, but we call it silent, meaning I have the inflammation, but maybe I have a really high pain tolerance, or I don't experience the symptoms of endometriosis, but maybe it's actually still going on, and that's going to cause inflammation and prevent implantation the way it would for another woman who has endometriosis. So then the question is, okay, what can we do? How do we test for silent endometriosis, right? The kind of the tried and true and by our guidelines in our society, the ASRM, is how do you diagnose endometriosis? You basically have a clinical suspicion, and then you get documented laparoscopy with pictures or potentially pathology to document endometriosis. That's the tried and true gold standard for diagnosing endometriosis. There's a company that came up with a special test that it's called the Receptiva test. It's essentially where we can do a biopsy. We can take cells of the lining of the uterus and send that off to a special test where they have a proprietary way of testing for endometriosis. It's this company that does it, and it is not. I will tell you, it's not backed up by a whole lot of data that supports it. But then the question becomes, it becomes a conversation with the patient. It is something we can offer. I offer it in certain situations, and it really becomes a conversation because, the ultimate outcome is that if it's positive, well then at that point, do we want to do 1 or 2 months of Lupron to quiet something that potentially you're not even experiencing? So it's a conversation, and it's something that we can offer. It often delays the embryo transfer by multiple months because we need to do the test, we need to wait for the results, and then it potentially locks you into 1 or 2 months of Lupron. And so it's a conversation to have. So that is the Receptiva test. The other question is, can you do an MRI for endometriosis? Absolutely. So you can actually do an ultrasound for endometriosis. There's lots of ways you can look for endometriosis. The problem is that a lot of these imaging modalities don't pick up endometriosis. So sort of, as I mentioned, kind of like the tried and true gold standard for diagnosing endometriosis is going to be with a laparoscopy, with visualizing it or taking a resection of it and looking at it under the microscope and confirming that's in fact endometriosis. But if a woman has significant endometriosis with scar tissue and potentially even what's called an endometrioma, which is a cyst pocket in the ovary that has endometriotic cells, oftentimes you can see that on ultrasound, and you can see that on MRI as well. I don't know that MRI is really necessary all the time. I think the issue is that even MRI can miss endometriosis, but it can be a little bit better than ultrasound, so oftentimes we do it, and I think it's just part of putting the picture together and thinking about whether that's indicated or not, but it can be used. Let's see if there are any other questions. I know I kind of talked a lot today. I thank you guys for hanging in there. So will endometriosis impact your pregnancy? So, that's a very interesting thing. So can you experience more health issues? So not as far as we know. So, what's interesting about being pregnant when you have endometriosis, and this is not exactly answering your question, but it's related. So actually being pregnant while having endometriosis, remember we talked about how endometriosis can be progressive, right? So endometriosis, as you get older and you're living with it, if you're not suppressed with Lupron or birth control pills, the endometriotic cells grow, get inflamed, and get worse, and potentially increase risk for scar tissue and implants and all of those sorts of things. Being pregnant actually can suppress endometriosis as well, and so that's the good news. But then once you stop being pregnant, the endometriosis just comes right back again. And can it impact your pregnancy? Not really. The only thing, again, that we talked about is that endometriosis can impact your ability to get pregnant because it can affect the egg quantity, the egg quality, the health of the eggs, and success in fertility treatments, including IVF, and also can affect your chance of pregnancy because we talked about the structural issues and the scar tissue that can develop. Also, we talked about potentially, and again, there's not so much evidence on this, but the thought is that potentially if there's inflammation and endometriotic cells within the lining of the uterus, that can impair implantation. And so not necessarily that you'd experience health issues or impact your pregnancy, but it can affect your ability to get pregnant, to conceive. And in terms of health issues, I mean, if, not related to being pregnant, but just endometriosis as women, get progressive disease. I mean, pelvic pain and scar tissue can lead to significant issues in a woman's life. Her ability to function normally, and can, really lead to lots of things, even including mental health issues. So it really is something that needs to kind of be dealt with sooner rather than later. Any other questions? Okay, well, it looks like some people are just joining. I know that this is recorded, so for those of you just joined, please feel free to watch this from the beginning once this gets reposted. I encourage you guys to reach out, keep asking questions, press your doctors for answers. You're more than welcome to reach out here. I'd be happy to speak with any of you in person or by telehealth visits. I see patients in Beverly Hills as well as Pasadena. And I thank you guys for tuning in today, and have a great day. Thank you.